Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric OKelly. This week, I am with Dr. Tom Mallinson. Tom has been on the peripheries of the college for over 10 years and then joined as faculty member, was it 3 years ago, Tom?
Yeah, I think it's 3 years now, yeah.
So you and I met in Wexford, Ireland, when you came over for a MIRA course when you were still a wee paramedic. Tell us about that experience and why on earth were you trying to learn about austere medicine?
Yeah, that was a good little course, wasn't it? That was nice. The things I mostly remember about that was arriving in Ireland and it was just so green. And I was just like, oh, this is lovely. I can see why these guys are based over here. What was I doing at the time? So I came to do that because I was enrolled on the fellowship of the Academy of Wilderness Medicine, the FORM program. And that was because I think I was doing a bit of pre-hospital care. I have a background as a paramedic and then went to med school. But it was the fellowship that basically prompted me to look around for more interesting courses and courses that took you out of, you're in a hospital, just press this button and someone will come and help you. So that's how I found the MIRA course, which was really nice. It was a really nice multi-professional course, wasn't it? Because I think there was a ton of offshore medics on that course, if I remember.
Yeah.
Like a couple of nurses, a couple of paramedics. And just really nice being on a course where everyone is seeing patients, everyone's treating patients, but you're all approaching it from a slightly different angle. And that course gave credits. So that was how I found it, and that's why I zeroed in on that course. So yeah, that was really good, wasn't it? And then caught back up with you guys, 3 or 4 years ago.
Yeah.
With the college.
So tell us a bit about yourself. Tell the listeners who Tom is and why are you with the college?
So I guess my role with the college at the moment is a kind of senior lecturer post, looking after year 2 of the bachelor's program. So that's the Bachelor's of Remote Paramedic Practice, which is a really great course. It's really interesting to be part of that because, again, you've got candidates, you've got international cohort of candidates, which is really interesting, and it means I'm learning from them, and we're sharing practices from around the world, which is great. But in terms of how I got there, I was a paramedic first. So I studied at the University of Hertfordshire in England and did that alongside the London Ambulance Service NHS Trust. So that gained me a bachelor's in paramedic science. So in the UK, paramedic is now it's bachelor entry. So you have to have a bachelor's degree to be a paramedic in the UK. So I completed that. Worked for London for a couple of years. So London is a great experience if anyone's thinking about coming to the UK as a paramedic. I'd recommend London. You get huge patient exposure. There's clearly a bit more violent crime. There's more people, right? And then obviously you get the increased risk of adverse incidents, terrorist attacks, industrial incidents. So London was a good experience. Loads of patient contact, CBRN training. Like hazmat training and a bit of training in practice placement education, that kind of stuff, training more students because we have a load of students coming through from all the universities running paramedic science.
Were you a heart paramedic as well?
So heart didn't exist back in the day.
So you were a heart paramedic, they just didn't call it that.
So heart didn't exist back in the day. Well, so I was a CBRN operative, which I think sounds cooler.
Sounds sassy.
Yeah. But so basically it meant you could put on a powered respirator suit and you could wander around in the warm zone. But then back in the day, we didn't really have the technical rope rescue capability and expertise in the ambulance service. So you would just the fire service might give you a harness and they'd look after you and they'd push you over the edge of something, but they'd be in charge of that. So yeah, heart only occurred after I'd left London, which is a shame because I think that would be good fun. So yeah, then I jumped ship and went to med school. So I went up to Warwick Medical School, which is in the Midlands of England, and that was very interesting. It was eye opening how much medicine there is to learn. and how even spending years learning it for your medical degree, you still don't know all of it at all, even closely. And then after that, I knocked around doing some house officer jobs, so some junior doctor jobs, and I did a bit of anaesthetic training for a couple of years, and then moved up to the Hebrides in Scotland to do rural general practice, so rural family medicine. That included more pre-hospital care, and then along the way I also was a mountain rescue doctor for 2 teams and was a Coast Guard. So I was in Her Majesty's Coast Guard, clearly His Majesty's Coast Guard now.
Was that when you were in Guernsey? Because you were a paramedic in a very remote location in Guernsey Island, which is basically France, isn't it?
So it was Jersey. Jersey's much better than Guernsey.
Oh.
No rescuing there, but that job entailed some retrieval medicine work, so some fixed wing retrieval work. So we had to fly off island. A lot of our cardiac cases, we flew off island for secondary angioplasty and angiograms, and we flew off neurosurgery. So we had a few neurosurgery flights into London City, so that was good. And we flew some of the more complicated liver patients. We flew off island as well. So that was quite a nice mixed bag of interesting transfer medicine, even though it's quite a short hop. Clearly, you're over water, you're flying through international territory and over France. So there's some interesting questions there on if someone dies on the plane, where do you land and how do you do the paperwork? So yeah, I finished med school. I went to Jersey, 2 years on Jersey, then back up to the Midlands for anaesthetics, 2 years anaesthetics, and then up to the Hebrides, and then a couple of years on the Hebrides, and now I've moved back to the relative luxury of the Scottish Highlands.
So why Scotland? You're in very remote areas of Scotland. Why did you choose that?
Well, so firstly, for anyone listening from Scotland, obviously Scotland is the best place in the world. The weather up here is surprisingly good. We just tell everyone it rains all the time. So today, for example, it's sunny and it's warm and it's lovely. There's loads of opportunities for pre-hospital care for me. So Scotland still has Basic Scotland as a pre-hospital care scheme, facilitating volunteer doctor, nurses and paramedics responding across Scotland. So that's great to be part of. It means I get to support the local ambulance crews. Hopefully I'm on good terms with them all. I think I get on with them. And it's nice to be able to support them. And because you're rural, you still get to make you get to make really good patient-centered decisions about what they want to do for their care. Because some people don't want to drive for hours to get an X-ray. They'd rather you examined them and you gave them your best opinion, and they'll see how they get on. And the flip side of that is equally you get the farmers trampled by cows who either won't come and see you, or they'll still be lying in their barn when you get to come and see them. So for me, there's still that really interesting mix of clinical medicine. And from a personal point of view, I got to move up here and live on a small holding, so like a really small farm, which is great for me. So I've got a flock of sheep and a flock of rare breed chickens and a couple of peacocks. So that's good. So my day off yesterday, I was butchering a couple of those chickens.
You told me a story where you're shearing your sheep halfway, and then you got a medical call. And so you had a half-sheared sheep wandering around your farm for a week before you finally got back to it.
Oh, yeah. Well, so she was wandering around the farm for a whole season because she was the hardest sheep to catch. I don't know if anyone listening shears sheep. My wife and I aren't very good at shearing sheep. She is much better than I am. But this sheep hated us. So we'd started from the tail moving towards the head. And we got, 3/4 of the way through. And then there was a cardiac arrest in the village, so we had to leave to go to that. And then so we left this poor sheep with a massive mane of fleece. So she looked like some sort of mountain lion. And we had to leave her for a whole season because we couldn't catch her again. So then when we caught her the next year, she still had this huge mane of fleece. So yeah, there's some interesting challenges up here.
I remember you telling me about a paper you just got published on the fact that it is faster to drive a patient that you just stabilized than it is to wait for HEMS.
Oh, well, yeah. So I would encourage anyone to go and look up this paper. You've put me on the spot now because I don't know the reference, but it's published in the Air Medicine Journal. which hopefully loads of you are familiar with because it's a good journal, I think. And our paper is about, so we looked at a subset of patients who were the motorcycle accident patients in the Highlands. And we looked at their transport times by land or by helicopter. We had a sub-question about whether having a doctor on scene slowed things down, because everyone knows that doctors like to pontificate and throw in some Latin and waste time. Fortunately, we found that a doctor on scene didn't slow down things, so that was good. We then looked at the main question, which was, should we be putting these patients in helicopters or should we be transferring them by road? So obviously, a helicopter is much quicker once it's going than an ambulance, right? So the speed limit here is 60 miles an hour on all these roads. You can push it a bit beyond that if you're using lights and sirens, but realistically not a big deal further. Whereas a helicopter's just flying in a straight line, right? So it's, apart from the mountains and the way, it's fairly quick. But we found that once you take into consideration the helicopter landing, finding somewhere to land, landing, shutting down, us bringing the patient to the field that they've landed in, loading the patient, taking off, flying, landing at the hospital, waiting at the hospital to offload to then get into ER, A&E, the emergency department. We found that within a certain radius, you were just quicker putting them in the ambulance because the extra faff time at either end of the helicopter kind of adversely affected the benefit you were getting from a really, really fast aircraft. So I think that was fascinating. And if you do a little search of the literature for the word isochrone, so isochrone just means same time, you will get some really nice graphs of circles around hospitals within which it's probably quicker to put your patient in the ambulance rather than fly them.
You must have met some very good friends on the HEMS when you published that.
Well, so far, I think either no one's read it or the people who have read it have been fairly positive. Because what we're equally saying is we've essentially drawn a squiggly line around our hospital. We're essentially saying out with that line, there is benefit in the helicopter. And beyond that, the maximum benefit from that helicopter is if it's already on scene. So what we're actually saying from a HEMS HeliMed point of view is if you think a helicopter might be useful, you need to dispatch them immediately because you want them on the ground, shut down, doors open, ready to receive a patient. What you don't want is an hour later to think, oh, you know what would be helpful here, a helicopter, because that delay just burns time for the patient. So yeah, the flip side is we're saying how important it is for early, accurate dispatch of helicopters. So hopefully we didn't rustle too many feathers.
Hopefully.
But I think that was an interesting paper. There's only a few people that have looked at the same clinical question or the same logistical question.
I'm trying to remember, and Pints might have been involved. You told me a story where you got to a patient and put him in the ambulance and then made that calculation of calling the HEMS. The HEMS came, picked up the patient, and then had to refuel and then landed in the hospital, but couldn't offload the patient unless it went to an ambulance, then drove 400 meters. And your ambulance was the one that was dispatched to meet the helicopter to collect your own patient back from HEMS. Or am I misremembering that?
Yeah, so there is the issue, and it's not just a Scotland issue, so I don't want this to become a focusing on Scotland. Unless your helipad is adjacent to your hospital, as in 200 meters, you probably then need an ambulance to rock up to accept the patient off the helicopter to drive them to the front door of the hospital, right? And there's loads of hospitals out there, certainly in the UK, where we've had to put the helipad in the car park because structurally we can't put them on the roof of the building. So for all of those, there's that delay that unless you have an ambulance waiting to pick that patient off the helicopter and drive them half a mile across the car park, you're just adding delay. And we've certainly had some where perhaps you've loaded them into the aircraft and then the aircraft doesn't have enough fuel to reach a hospital. So they have to fly and refuel with the patient. Clearly, that's not ideal. There's risk involved in there. There's additional delay, and if you start adding up things like the aircraft needs to refuel, the aircraft needs another ambulance to meet it at the hospital, you're losing the benefit of your helicopter as a transport platform. Clearly, there's the other question of if your helicopter is deploying enhanced care, that's a separate use for the helicopter. So we're focusing on logistical time benefit. So yeah, we've had a few instances like that where, in retrospect, you think, oh look, that patient would have been 1 or 2 hours quicker just driving down the road. And it might be that driving down the road is an hour and a half in the back of an ambulance, and you think, oh, that's a long time. That's a long time, right? Say 2 hours in the back of a truck, and you think a helicopter is obviously going to be quicker. But then in retrospect, it wasn't quicker because it had to reposition. So you had to then drive half a mile. Then you had to load the patient into the heli. Then they took off. Then they had to refuel. Then they flew to the hospital, but they couldn't land at the hospital because there was another helicopter on the helipad. The helipad's out of commission. There isn't a helipad, so they have to land a mile away in the village, in a field, and then they have to wait for an ambulance to pick them up. And then in retrospect, you think, oh, we really didn't do the best for that patient because we added delay to their care. So I hope that's the subtext of that article, because we cards on the table, we just looked at a very small subpopulation in that study. And I say me, but that was a med student guided piece of work. That was a fantastic piece of med student work that we then adapted for publication.
So you mentioned clinical access. So if you have a HEMS doc and you as a basics doc arriving, is it the same? Like, is there any clinical enhancement that the HEMS brings to your practice if it's just you and...
Yeah, there definitely is. So
a couple paramedics.
The Scottish system has a tiered model in pre-hospital care, which is color-coded for simplicity. So we have a green, yellow, and a red level responders. So green level responders are our road paramedics. So that's your standard paramedic. They can give morphine, they can give Penthrox, they can give tranexamic acid, and a few other bits and bobs. I say a few other bits and bobs. They can do a lot of meaningful pre-hospital care. And then you've got yellow resources above that. So as a basic Scotland responder, I'm a yellow resource. We've also got advanced practitioners in critical care, so they're paramedics and nurses. And I in that group have a few skills above the green resources. So we carry a bigger range of drugs. We have ketamine. We have, what else do we have? Things like magnesium, and we can do things like front of neck access, chest drains, things like that. And we're perhaps a bit more free in not having to follow protocol and guidelines. So we have that more autonomous approach. And then above us, you have the red resources, the red teams. So the red teams in Scotland are the EMRS or the ScotStar teams, primarily funded for their retrieval purposes because Scotland is huge and it has quite a lot of islands with people on them. But those red teams can also be pre-hospital responses. So they carry with them blood, so they can give blood products, and they can also give roadside anaesthesia. So in the UK, to provide roadside anaesthesia, there's a core standards, and one of those core standards that's very clear is it should be in a well-governed and kind of well-oiled team, and it needs to be a team approach to pre-hospital anaesthesia. So I have anaesthetic competencies, so I could walk into the street and I could give someone an anaesthetic, but it would probably not be safe to do that individually, autonomously, not in a team.
It is nice to have to bounce ideas back and forth on people. Yeah.
Yeah, giving someone RSI when you have to be 100% responsible for airway and monitoring and drugs because no one else there with you knows what you're pushing. Like there's only so far you can push. You can say, oh, just give the big syringe and then the little syringe and we'll hope for the best. Yeah.
Yeah.
So we've got the red teams knocking around who provide those additional interventions above and beyond what the yellow and the green responders do. So in answer to what your question was, when one of the red teams, so the helicopters are staffed. Some of the helicopters might be deploying red teams, so they would bring those extra skills to the party. So that's the added benefit they would bring.
It's similar with the HEMS experience I have in Hungary, where they'll have a doc and a paramedic on the HEMS. And some of the calls we would have a ground doc already stabilized patient, and then there's a team approach with the two docs and the three paramedics and discussing that clinical case. But sometimes you're arriving with not even a paramedic. There's a EMT that is with the patient, and so it kind of has both ends of the spectrum. But it sounds like the Scottish system, you always have a paramedic arrived, and you may or may not have a basics doc arrived before the HEMS comes.
That's the theory. So yeah, in theory, you should get all of those responses. But equally in my role, I might be the first on scene at an RTC at a car crash. In theory, it would be nice to have some help there. But then equally in those situations, I'm not really doing any enhanced interventions. You've got to make the scene safe. You've got to approach your ABCs, right? So before you get on to doing things fancy like nerve blocks or ketamine, you need to manage the basics, don't you?
Yeah.
So hopefully there's some people there to help me rattle through those basics first. But yeah, sometimes you're the first one there, and you have to get on with things, which is quite fun.
That's part of the fun of being an austere medic, isn't it? It's just you against the challenges of that case.
Yeah, it's the challenge, isn't it? But then it's quite nice after a while to have someone else turn up.
Definitely.
So that you can run everything past them. You can say, this is what I've done so far. What are we missing? What else do we need to do? What's next?
Tom, you just recently purchased a butterfly. You are now faculty teaching on our APIS courses, and you're helping us design the PG cert in austere and pre-hospital ultrasound. How has access to, so you have your own IQ butterfly, and now it's with you all the time when you are treating patients. And you've had it for a month, so this is a good question for you. 4 weeks after your access, how has that changed your practice? How has it enhanced your ability as a doctor?
Well, so I'm going to start by saying I have no financial incentive with Butterfly, but if Butterfly are listening, it is a great product. So firstly, I have found the Butterfly specifically as an ultrasound device really, really user-friendly and has loads of add-ons that are so helpful. So earlier this week, I was scanning someone, and the Butterfly just has a button for very simple bladder scanning. But you press the button, and it does some clever moving the direction of the array. I have no idea how it works, and then it just plops out a number. It has automatic ejection fraction calculation, and the interface is just really, really helpful because pre-hospitally you don't want something that's too fiddly. But I'm not being paid by them. So if anyone else wants to send me a different ultrasound, I'll try that too. But yeah, ultrasound's really helpful. I use it most for fast scanning. So I mostly just do extended fast scanning, so chest, lungs, heart, and free fluid in the abdomen. So use it for that, and then a bit for nerve blocks, a bit for vascular access. So again, flying the butterfly flag. Butterfly scanner has biplane view, which lets you have a longitudinal and cross-sectional view at the same time of the vessel that you're venipuncturing. That's amazing. And then what else do we use it for?
Nerve blocks.
Nerve blocks. I was using it on someone's renal tract the other day. Butterfly gives surprisingly good resolution for renal tract, so that was really helpful. So I'm not an expert in this bit, but other members of the pre-hospital team I work for, they've been doing a bit of work on identifying fractures using ultrasound. I haven't had anyone that I've needed to do that for, but there's a few papers out there from Luke Regan. So he's one of our consultants in Inverness, who's done quite a bit of work on the utility of ultrasound for fractures. So I think ultrasound certainly adds a lot, doesn't it? But you just have to be mindful of its limitations. I think you have to remember that this isn't an all-seeing eye that's telling you the answer. It's just more information for you to make a decision.
It's one more data point for your practice, for diagnosis. Yeah.
Oh, so the other one bit of extra data point is having a quick look at the vena caval collapse. For are they well filled? Are they dehydrated? That's hugely beneficial. That one intervention, because that really can guide your treatment. Because it gives you that quick answer of this patient's really underfilled. I can give them 500 mils or maybe a litre of IV fluids and look for a response. Or you put that on and you think, oh, they're really well filled. This isn't a filling issue. This is either a pump issue or a distribution issue. So that's the other scanning modality that is really, really useful in my practice. Anyway, I found that really useful. But yeah, it's an extra bit of data, isn't it?
Yeah. In that situation, having a pump issue, you can look at the D shape of your ventricle to see if there is some hypertension, pulmonary hypertension.
Yeah, we've had a few that have been quite frustrating, where we've had people just going into arrest, and pulmonary embolism is on the differential, but by the time we've got the ultrasound machine out and they're in arrest, I don't think there's as good validity in looking at that right heart morphology, because once you've been in arrest for a while, it's going to be dilated and engorged, isn't it? So we've had a few that's been really frustrating. I certainly haven't caught anyone early enough where I've been able to do a quick bedside echo to support a PE finding. But I think that would be really handy. I think if you got the right patient, that would be a really beneficial data point.
So are you the only practitioner in your area that has a POCUS? Like no paramedic, no other physician carries it?
So the trauma team I work on out of Inverness, we carry an ultrasound on the team. But I don't think anyone else up in my patch has an ultrasound. A few of the other travelling or visiting rural docs have butterflies as well. So some of the docs that go over to the Hebrides, to the Uists, I know definitely carry their own ultrasound. And a few people on the Northern Isles, like the Orkney, Shetland, every now and then there's someone knocking around with an ultrasound. I think for us there's still a cost limitation, because the NHS isn't particularly rich, and a lot of the stuff I do is charity based, and charities aren't necessarily very rich.
Well, if you keep putting out publications on the benefits of what you're seeing in austere medicine, rural medicine, and how POCUS helps, maybe that will make a difference.
Yeah, I mean, that's what I'm hoping. I think the more we talk about it, and some of that talk will be where it's not beneficial, right? We equally need to say, we thought ultrasound was going to be helpful for this patient group and it wasn't, or worse still, it was actively harmful. So I think we need to keep an open mind of, are we causing detriment to patients by scanning them? So I'm not saying that the ultrasound is the answer, and I think it brings many benefits. But I hope, as you said, that the more we delve into that and the more we publish and the more data points we have, I think we will find that it's really beneficial having pre-hospital and austere ultrasound. I think that is the answer. But equally, I will be keen to do any research that tests that theory. And if I'm proved wrong, that's fine. And I'll give back my ultrasound and I will stop playing around with it. But I think the data we have so far shows that it's beneficial and not harmful to patients, I think.
Yeah, the harmful one is going to be a hard sell for me to see data that's going to prove that. But the beneficial, there's enough out there from the States and from other places that are showing the benefits of ultrasound. It's just a matter of maybe getting some from Scotland.
Yeah, and certainly the last time I think about a month ago, I had a good search for does ultrasound cause delay on scene pre-hospitally, and there wasn't data saying it did cause delay. But I'm not sure that question has been looked at robustly enough, because I think that's an easy way we could cause harm to patients. You know, if I say, oh, let's hang around, guys, let me do I'm going to do an E-fast, and I'm going to do an echo, and I'm going to do this, that, and the other. And if I'm just burning time, and that patient's slowly bleeding into, if they've got a spinal fracture or a pelvic fracture that's slowly oozing, or they're getting cold because I've undressed them and covered them in jelly.
That's a valid point in austere medicine, isn't it?
Yeah, and I've certainly had a few where I've been scanning on the roadside in adverse weather conditions, and it's been a challenge to keep them warm because you're moving around their tummy, scanning them and covering them in jelly. And really, you need someone following behind your scanner, mopping up the jelly and pulling that blanket back over them. So I think there's that risk, and I think we should be open-minded about the harms and benefits.
Are you not using a Bothy shelter, even though you're working out of a car?
No, we have a load of the slightly more expensive foil blankets, and to be honest, people in Scotland are excellent. So in general, if someone's been stuck on the roadside for a while, you'll turn up and someone has created a tent over them. Whether that is other walkers, mountain bikers, or people just coming out of their houses and bringing furniture out their houses and creating a tent. So we haven't yet. We've talked about it and we've looked at the options, but no, not yet.
That might be an interesting study, and not that dear of a price to do this. What's it? 60 quid per Bothy shelter.
Yeah. The only exception to that is for the winter months, I do put in some big foam pads into the back of my car. So if I have someone on the ground, I can at least isolate them from conductive heat loss. But I also need to limit what I put in my car, because otherwise it will not have any room for the dog and for shopping.
And sheep.
Yeah, and sheep food and all of that stuff. Yeah.
So you just wrote another bit on a textbook. So your name is out there quite a bit on some of the paramedic textbooks. And this recent one that the publisher just sent me is Primary Care for Paramedics. Can you tell us about the textbook and your chapter 2 that you wrote?
Yeah, it's Primary Care for Paramedics. That's another publication from Class Publishing in the UK. So if you're an international listener, Class Publishers in the UK, they have quite a good array of paramedic books now. Written for the UK sector, so some of the law, legal stuff in there is going to be UK based, but they have global appeal, I think.
Indeed.
This book is... I'm just trying to find the chapter list. So this is a really good edited book by 3 very clever people who very kindly, so Georgette approached me, one of the editors, and asked me to contribute chapter 2, which is consultation skills and the diagnostic process, which you can read for free on Google Books, in the UK at least. So I have had to squeeze into that chapter everything about consultation skills, a bit about breaking bad news, a bit about diagnostic modelling, how to make a diagnosis, and then a bit about red flags, and then how to safety net, how to finish your consultation and safety net a patient appropriately. So that is a lot of information that I've tried to squeeze into that chapter. In terms of the rest of the book, it's pretty chunky, it's pretty comprehensive. So you've got chapters covering laboratory investigations, multiple other chapters just go through system-based approaches, so mental health, eyes, ears, nose, throat, gastrointestinal, all that kind of stuff. There's some palliative and end-of-life care at the end. There's a bit of chronic pain, a bit of safeguarding, So it's a good, solid, comprehensive book for those kind of wanting to stretch themselves in terms of urgent care and primary care, or for the UK, a lot of paramedics are now moving into primary care. So I think this is a nice book to nudge your thinking towards primary care thinking and a bit more of a global view of your patient and a longitudinal view of their care.
It's definitely applicable for austere medicine as well, because when you're in remote medic, you are primary care. You do that. Everyone loves the sexy trauma stuff, but it's primary care that we're seeing.
Yeah, I think the two prongs are your primary care, but then you are primary care in that longitudinal fashion. So I guess you're urgent care for the minor ailments, but then also you're looking after that patient for 2 months, 6 months, even 6 hours. You have to start being a bit broader, don't you? You have to have that prolonged field care approach of not just thinking, oh, they've sprained their ankle, but are they dehydrated? Are they getting up? Are they eliminating? Are they getting pressure sores? Which I think the primary care mindset puts you into that longitudinal frame of mind a bit better, because it moves you away from, oh, I've given a dose of antibiotics, tick, I've done that, to when do they need their next dose of antibiotics? Is this appropriate antibiotics? When does that wound need cleaning? When does it need redressing? So yeah, I think it's extremely relevant to the austere medic, and as you said, just dealing with the minor complaints. Obviously, the risk is minor complaints are only minor until they're not, and you need to pick up the ones that either aren't or the ones that are becoming serious. Which I think you can only do if you know your craft, don't you? You need to know what you're doing to identify when something is not a minor condition. So I hope this book is good for that.
So you wrote about safety netting and a little bit about red flags. At the college, we push heavily on the concept of red flag as you go through your CABCDEFGH algorithm.
Mm-hmm.
But I think we missed the back end of it, which you wrote about here, which is safety netting. So tell us about safety netting and why it's important to the remote medic.
Yeah, okay, so going back to safety netting. So safety netting as a concept was introduced by Roger Neighbor. And if anyone is interested in how to talk to patients and how to elicit information from them and how to get patient buy-in for a management plan or how to negotiate a management plan, Roger Neighbor has written a load of really, really good stuff on that. And he's still around. There's some YouTube videos of him talking about how to consult with a patient over the telephone or over video conferencing. So he's a wealth of knowledge, and I'm partly just stealing what he's already done and sharing it with people because I think it's great. So Neighbor introduced this concept of safety netting, which is what it says on the tin. Really, it's you've examined them, you've taken a history, you've given them some treatment, and you've said, there you go, mate, that's what's happening. And then you need to safety net them so they don't get worse. So safety netting really incorporates everything from come back and see me next week and I'll have another look at your ankle. Or I think your ankle could be broken. I'm going to write a referral form for you to go and get an x-ray. Or I'm going to order the minibus that's going to take you down the road to the place with the x-ray. So it covers all of that, but then more in a more focused manner. When we talk about safety netting in the UK, we really mean the advice you're giving to your patient. So for you guys who are austere or you're running your own clinic, often in those places, by the nature of the place, the people you're consulting with are pretty independent. If they're anything like the Highlands of Scotland with the farmers and the crofters up here, they are not people that are going to be eager to come back and see you, because generally they manage their own health conditions, right? And they're very competent at that. So your safety netting is if things get worse, this is what you're going to do. Because a lot of people will think they've seen someone and they've had their consultation and they've had their treatment. So why would I need to go back? The medic gave me these antibiotics. He said that would sort the problem out. So I don't want to bother him again. Mm. And you want them to come back, right? Because it's much easier if they come back day 2 and they say, oh, look, this infection in my leg hasn't got any better. Like, I would rather see them day 2 than see them day 5 when they're unconscious with a fever and they're rigorous and they're delirious. So you're doing your patient a favour and you a favour. And we want the best for our patients, right? So this is rounding off your consultation to check things aren't going to get worse while you're not around. And I think one of the challenges is certainly in the UK, there's the habit in your documentation of saying patient safety netted or patient given safety netting advice. And what does that mean, right? That could mean, if you get worse, come back. Or maybe it means if you're not better in 5 days, come back. Or does it mean if you develop central crushing chest pain, come back? So I'm just trying to nudge practice away from being generic in our safety netting, our advice to patients, to being a bit more guided, a bit more specific. That was my plan for this.
So I guess it's easy for us to have the fire and forget mission. Oh, great! I sorted this and head off and do your thing. And this is a way to make sure that the patient doesn't get worse without you knowing it. And when I've worked in austere clinics, I've always had a policy of breakfast and dinner. So regardless of what jobs you have or what you're doing out and about, you're always going to be there for breakfast. You're always going to be there for dinner. So if I have somebody that I've managed a pretty decent laceration and I've bandaged them up, it's just policy. Every morning and every supper, come see me. Let's take a look at that. And I guess that's the only safety netting that I've done in the past.
And that's really good, right? So because you have that set structure, but say you're on one of these jungle expeditions where maybe there's multiple camps and you're at base camp, you might not have that opportunity to catch someone morning and evening. Or if you've got a larger population and you're providing more of a primary care, general practice, family medicine, it's much harder to, and you don't want to bring back everyone, right? Because if you're seeing 30 patients a day, you don't want to review 30 patients every morning and every night. So you need to devolve a bit of responsibility back to the patient or to the patient's parent or guardian. Because sometimes you can't have that luxury of breakfast and dinner reviewing people.
So you need to give them right and left limits on, all right, if, like you said, if there's a crushing pain, or if there's hot or there's streaks coming from the wound going towards the heart.
So I've tried to delineate safety netting into 4 headings, which make you think about those headings and make you double check that you've told the patient. Because you might have seen that person with a laceration and you think, oh man, if pus starts coming out of that, I hope they come back. If they get tracking redness, I hope they come back. If they get some big lumps in their armpits come up, oh, I hope they come back and see me. But you need to make sure you've told the patient because you're the medic and they might not know that, right? They, if they're an expert in being a plumber, being a carpenter, maybe they have no idea about medicine. In the same way I would have no idea when my tap's leaking. I need someone to tell me what the red flags are.
Right.
So that was my plan with this framework. So the framework is it's 4 headings for safety netting. So the 4 headings are general safety netting, logistical safety netting, red flag safety netting, and then risk and refusal safety netting. So it's only 4 things, which is achievable because you don't want to add as you said, you've already dealt with the problem, right? You've examined them, you've taken a history, you've managed them, you've given a treatment plan. So this isn't meant to take up loads of your time. Essentially, it's a reminder. So your general safety netting is what you should be doing for every patient anyway. If you feel worse, come back. If you feel worse, get in touch with someone. And every single patient you see, really, you're going to say that to, right? So general is just remember to empower your patient that they are free to come back to you. Because it's very easy as a patient to think, oh, I've seen the medic. They told me this is what was going on. They gave me these tablets. I don't want to bother them again. And probably you would rather they bother you again, right? So the first bullet point is really just empowering your patient to come back. And so in my situation for pre-hospital care, I will sometimes say, look, if anything gets worse or you're worried, you need to phone back. And I will add, even if that means I walk out your house and I go and sit in my car and something goes bad, like, you can come and get me even before I've driven away. And you can say, oh, look, I'm worried, something's changed, something's bad. Or if I've just driven down the road and then something changes, you develop chest pain or you suddenly get difficulty in breathing, you can phone back straight away. So that's just general empowering your patient. The next one is logistical safety netting. So especially important for the austere environment. So as we know, one of the headings for your prolonged field care is logistics and communication and that kind of stuff. If I'm on an expedition or I'm in base camp and my patient has gone off to do something else, what is the logistical plan for them getting medical advice? Is it phoning base camp? Is it phoning top cover directly? Is the logistics there isn't comms, and I want them to physically come back here? From a more kind of domestic setup, when I'm safety netting someone, do I want them to phone 999, 911? Or is there a more appropriate option? Am I saying, if you develop central crushing chest pain, you should phone an ambulance, but if you develop a niggling elbow pain, you should phone your own GP, your family medicine doctor? So that heading is to be clear that they know how to seek help and which avenue to go down. And for us, that's specifically useful for people who are fairly naive to the health service. So typically that's your 20-year-old man who's cut his arm, right? Men generally don't engage with healthcare very much. They don't have need to seek primary healthcare, so they will probably be more naive to, there's a walk-in centre in town, your GP is open from 8 a.m. to 6 p.m. and this is the phone number. This is the out-of-hours GP phone number. This is the emergency department. This is where it is. So it's really good for those people, and it's really good for tourists. Because if you imagine you're a tourist somewhere, you've got no idea, right? You don't know if there's a walk-in centre or a minor injuries unit, and what's the difference between those, and where should I go? So that's your logistics heading.
So it's kind of like a PACE plan: primary, alternate, contingency, emergency, and logistical and communications, like your command and signal on where, who do you talk to if anything changes?
Yes, yeah. So you could probably slide PACE in there, couldn't you? And it would tick the same. That's just another way of thinking about that logistics, isn't it?
Yeah.
That would have been good. I should have put that in the chapter. I'll put that in the second edition if they invite me back.
Fair enough.
But yeah, so that's basically just reminding you to check the patient knows how to do that stuff, and to make sure you know how they're going to get back in contact with you. Right? There's no point in them thinking they're going to phone your mobile, but you think that you're going to turn your mobile off overnight.
In the jungle, that makes sense. So your primary will be radio, that's the VHF
Yeah.
radio, or alternate might be satellite. And the contingency, well, you're not getting any electronic signals through the triple canopy jungle. So
Yep.
contingency is get your butt back into my clinic and let's have a look at that.
Yes. Yeah. So that's exactly it, right? And just think about sat phones, because it might be we only turn our sat phone on for 2 hours in the evening. So don't try and phone us in the middle of the day. But then contingency, if things are really bad, yeah, you need to schlep your way down here, don't you? So yeah, logistics, clearly really important, probably more important in the austere environment, because if you're in a village in the Highlands, like, you can phone 999 and you'll either get an ambulance or they'll redirect you to the out-of-hours GP. Next heading is red flags. So hopefully everyone's fairly happy with what we mean by red flags. So they're the big concerning features of disease, right? And we talk about disease-specific red flags and we talk about general red flags. So if you start losing weight without trying, that's a general red flag. If you have night sweats, that's a general red flag for a multitude of concerning diagnoses. But then specifically, if you've cut your finger and then your finger swells up like a big sausage, and when you try and straighten your finger, it's really sore, and when you press on the palmar surface of your finger, it's really painful, they're your specific red flags for tenosynovitis, right? That's your Cannavale signs, 3 of your Cannavale signs. So you've got disease-specific red flags and you've got general red flags. And these are the things that you've probably brought up in your consultation, because you've likely said to your patient, just to check, have you had any chest pain? Have you had any palpitations? Have you collapsed at any time? So this is just a time to refresh your patient and say, look, do you remember that list of things I asked you about? Chest pain, collapse, palpitations. If any of those happen, you really need to get back in contact with me. Or specific things. This cut on your finger, I think we've cleaned it really well, we've closed it. But if your finger swelled up like a big sausage, if you found difficulty straightening it, if it was really sore when you pressed it down here, I would want to see you immediately. That's your red flags, because you as a clinician know what they are, but that's not very helpful for your patient who is back out in the woods, in the forest, at home. They need to know what the red flags are, right? So that's just a heading to remind your patient what the red flags are. And equally, some of those red flags you're going to say if this thing, and then risk, right? So risk is kind of double pronged. I think of it as risk and refusal. So I think this is most important for people that have disagreed with your management plan. So if I've seen a patient and they've got central crushing chest pain and they look really pale and they're breathless, and I say, look, you need to go to hospital because you look unwell and I think you're having a heart attack, and they say, no, I'm going back to my farm, the risk safety netting is to be very clear with them of the risks involved. And it's an opportunity to say, I think the risk of you not going to hospital is that you might die. Or I think the risk of you refusing intravenous antibiotics is this infection could make you lose your hand. Or this infection could be so severe that you become septic and you collapse and you die. Because everyone needs to be very clear of the risks involved, and your patient presumably has capacity, which is why you've got to this level, and they can only make a valid decision if you've given them all the relevant information, right? So if someone with central crushing chest pain is refusing to go to hospital, everyone in that room needs to be very clear that they understand the risks. Because again, you understand the risks as a medic because you're thinking, they might they might be having a big MI. Maybe they'll go into VF. But does the patient truly understand, or do they just think, oh, I've got some chest pain and this medic's overreacting? So that's the risk bullet is maximally beneficial when they're refusing treatment, but equally if you're thinking in the austere setting, you've probably negotiated your management plan, because very rarely you will have gold standard care. You tend not to be in an austere environment with a giant hospital next to you. So you've probably done some negotiation. You've said, oh, look, this is quite a big cut to your arm. I think we've cleaned it and we've given you appropriate antibiotics, but we both need to understand the risk that this could become infected. And you need that shared understanding.
That has to be a challenge for you, Tom, when you're dealing with these stoic farmers, and I'm sure the farmers are very similar to what we have in County Kerry in Ireland, where their hand would be off and they still won't go in.
Yeah, and the thing that's really frustrating, obviously, is say 90% of the time they're right, because they've cut their hand loads of times. They've sprayed it with some purple spray that kills all known bacteria dead. But there is that risk, right? And I think that cohort often don't recognise that risk, because maybe they've been impaled by a bull multiple times and they were fine every time. But every time there's a risk, right? Every time there's a risk that actually this time you might not be okay. So I'm not saying that risk heading is to bully your patients into doing what you say, but I think it's ensuring there's a shared understanding of risk and being upfront about what that risk is, because it's very easy to say, oh, it might be better for you to go to hospital because you might get sick if you stay at home. What does that mean? Like that, I don't think that's very helpful.
If you add to that the fact that the farmer would have to drive an hour and 10 minutes to get to the hospital in Inverness, he's going to be more reluctant.
When he's in the middle of doing something that maintains his livelihood, right? So, and that's the same. If you're thinking more austere, maybe that person has got to go off, and maybe it's summit day, and they need to summit that peak, or maybe today is the day that they are going to go and ring the sea turtles, and today's the best day to do it. And if they don't do it, they've lost out on their funding grant to go and ring sea turtles. And you have to weigh up pros and cons and risk and benefit, because everyone's got other things to do, haven't they? Everyone else is leading their normal life. You're the only one obsessing about healthcare and risk, so you just need that shared understanding.
I understand why you put this into the primary care textbook, because it is important to have these 4 categories as you talk to your casualty.
I think so. I really believe in this, which is why I put it in there, because I think the risk, I like to think, if you guys go and look at the table, that if you miss out one of these headings, suddenly there can be problematic outcomes. You can do really good safety netting for your patient, but if they don't know the phone number to phone the clinic back, they'll be sitting at home being like, oh yeah, he said if I get worse I should come back, and he said these are the specific red flag bad things, but I don't know the phone number for the clinic. Or maybe like you're a traveling clinic, right? So you've moved on to another village. And then you've got that person sitting there being like, oh, he told me to come back if things got worse, and they've got worse, but I don't know how to get in contact with him. And so I think it's really useful. Equally, if anyone is listening and reads the book and thinks, oh, actually, there probably needs to be 5 categories of safety netting, do tell me, because this is merely my thoughts on what I think works well.
That's the beauty of feedback. Yeah.
So yeah, and we're all very accessible for feedback these days, being on LinkedIn and Twitter and all the other places. So again, like ultrasound, I think this is a work in progress. The evidence base behind safety netting is ropey,
So how do they get a hold of you?
Oh, that is a good question. So I'm on Twitter. I think I'm at Mallinson T, and I'm on LinkedIn as Tom Mallinson. I can't check my Twitter to check what it is because my phone is hanging out the window in a carrier bag, giving me signal to let me record this.
And then how do they get in touch with you at the college?
Oh, what is my college email address?
t.mallinson@corom.edu.mt.
That's the one.
So your Twitter is Mallinson T.
Oh, fantastic. But yeah, so that I think it's a good textbook. Again, now I've written that chapter, I don't actually have any financial gains if you buy it or don't, because I don't get any more money, even if you all go out and buy it. I think it's a really helpful textbook for people moving into primary care or people providing primary care who think they need a bit more support doing so.
So, Tom, what advice do you have for someone who would be interested in learning more about this? So you did mention class publishing, you did mention this textbook. Is there anything else out there for paramedics, nurses, junior docs to learn about primary care?
Oh, I think the challenge with primary care is all of medicine. So I would say that is the challenge. I think this textbook is accessible. There is another cluster of fantastic textbooks, and I'm going to butcher the name of the author. He is called Professor John Murter, I think. That is spelled Murtagh. Pretty sure he's John. He was a professor of primary care in Australia, and has written some fantastic, truly fantastic works on how to diagnose, how to consult with your patients, how to look out for red flags. He wrote lots on diagnostic triads. Of if you see these three things together, that probably means this diagnosis. He also wrote a fantastic book called something like Patient Education, which it's amazing. It's basically a big textbook full of information to give to your patient. So if they come to you with an earache, you can give them the pre-written information sheet of these are the things to look out for. This is how to self-care for yourself.
Oh, nice.
So I would say if you can, he has written some chunky textbooks on primary care. Professor John Murter, and his books are fantastic.
I have the Oxford Handbook of Primary Care and Community Nursing.
Yeah, so I really like the Oxford Handbooks. I find that for primary care, they go out of date quite quickly because they're very specific.
They do.
So yeah, I think the Oxford Handbook of General Practice is an excellent resource. It's a bit UK focused for UK guidelines, so it depends where you're working. But it is pocket sized, which is a benefit over,
Yeah, they are. I was trying to see what the latest edition is, and the Oxford handbooks are also just a wall of text as well, which is a problem.
Yeah, to plug another book, the Wilderness Medicine Oxford Handbook of Wilderness and Expedition Medicine, or Expedition Wilderness Medicine, should be out later this year, shouldn't it?
Yeah, I think so. Yeah.
It keeps getting pushed back, the publication date.
What I've appreciated about the class publishing is that in this primary care for paramedics, it's not just a wall of text, which the Oxford Handbook can be. This is well laid out.
Yeah, there was certainly a prompt from the editors to make it easily readable, and it has some nice red flag boxes throughout it, which is nice. There's a good dermatology chapter for all those people who dread seeing a rash as well.
Thank you for your time, Tom. I look forward to having you back here and in the next month, and we'll keep chatting.
Fantastic. Pleasure as always.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is CoROM, CoROM, corom.org.